let's go ahead, and I think to highlight a lot of the different treatment paradigms and strategies, which are obviously quite controversial, and there's no really great scientific data and high-level evidence yet in terms of what are the proper sequencing. But we obviously do have a number of really important trials that have reported over the past year. So I think the best way to do this, let's just talk, let's walk through a couple, I think, case presentations to sort of discuss basic treatment management. So case number one. In January 2015, a 58-year-old African-American male presents to the emergency department with abdominal pain, low back pain, and in the course of laboratory values, they discover he has a PSA of 251. He has a past medical history of coronary artery disease, insulin-dependent diabetic. On exam, he's a very cachectic African-American male, poor dentition, he has a nodular prostate. In the course of his workup in the emergency department, he gets an abdominal CAT scan, which shows multiple blastic lesions to the lumbar spine and pelvis, but no soft tissue disease. He's referred to urology and gets seen pretty quickly over the next week, undergoes a traditional truss biopsy, which shows a 53-gram prostate, 12 of 12 cores positive for Gleason, primary pattern 4 and secondary pattern 5. The urology department orders a bone scan, which is positive to the thoracic and lumbar spine, pelvis, right femur, and scapula. So this is a patient, obviously, that doesn't show up that often these days, maybe in some rural areas. So, Joe, if this patient was seen by you and your colleagues, your house staff, what sort of recommendations at this point? So we've got basically a very unusual patient that shows up with high-grade prostate cancer, metastatic disease, primarily to bone.
Our goal would be to start him on a LHRH therapy. We tend to use an antagonist in this case to get rapid suppression of testosterone within about 3 days. And then based on that, we will watch for his PSA response and symptomatic response to that.
Okay.
I think the one thing I would comment on, though, there was a nice abstract showing that since the U.S. Preventative Task Force the guidelines had been put forth, there's been an increase in high-risk disease presenting about 3 to 4% per year now in our clinics. So we are seeing more, not necessarily 251, but high-grade cancers presenting more so than we did in the first part of my career.
Are you seeing that also, Chris?
I can't say I've seen the shift after the task force recommendation.
You will.
But PSA screening is still relatively prevalent in our area, but the abstract you're referring to is, yes, more grade than stage, and so it's hard to separate that out, I think.
Right.
I remember, it was 40% in the early 80s before we had PSA screening, and we got well below 4%, and whether that number creeps up. But really, we're talking about less than 2% of patients still in the United States are going to present with this stage of disease.
Right. So historically, these were the patients that showed up to the urologist, and the standard has always been basically androgen deprivation therapy, whether it be monotherapy or complete androgen blockade. So, Dan, update us now on how this patient, based upon the new evidence that's come out, how should this patient be managed?
So this patient fits the category of a high-risk patient. If you compare this to Sweeney's data, or look at the types of patients that were treated on Chris Sweeney's trial, this patient has, looks like 5 separate sites of bone metastases. He does not have visceral disease, does not have soft tissue lesions, and this is the type of patient, based upon the data that was presented from the Charted trial, that should be considered for early chemotherapy. I think one of the interesting characteristics of this patient as well is that he is diabetic. One of the big differences in Charted between, one of the big differences between the patients treated in Charted and those patients treated on Tax-327 is the fact that there are no corticosteroids except for pre-medication involved, so you don't give continuous prednisone, so it's not an issue with a patient who's diabetic. But there was a significant improvement in survival. The hazard ratio was 0.6, meaning that there was a 40% reduction in the risk of death in those patients who received 6 cycles of docetaxel chemotherapy along with their hormone therapy versus those patients who had hormone therapy alone.
And again, in that charter trial, Dan, they stratified also between high volume disease and low volume disease. Is that something that has historically always been somewhat looked at by the medical oncology world in terms of that designation, which, if I recall, it was 4 or less
Right.
lesions on bone skin all to the axial skeleton, correct?
Correct.
For
It was
low
low
volume.
volume disease.
Low volume disease. I don't think that we've really traditionally stratified our patients in the D2 initial hormone trials based upon those exact criteria. But one would think that if we start thinking about mutations and complexity of the genetics, that the higher volume of disease has a better chance of having more genetic abnormalities, more mutations, and thus more drug resistance. So that would make sense that you're giving another agent. How docetaxel is working in this situation, whether it's through an androgen receptor-mediated mechanism or some other mechanism that we're not sure of, and why we're seeing such a great difference is not clear at this point.
And then there's a European trial, correct, that has been, I guess, reported out
Exactly.
Right.
today or most recently.
The Stampede trial.
Stamp-
Because there's 2 European trials,
Two,
one
right.
that was not in agreement data-wise with the charted trial, but we'll stick with the one that was positive since that just came out. And the Stampede trial, which was done predominantly in the UK, showed that addition of docetaxel to standard ADT in newly diagnosed patients with metastatic disease do benefit in terms of overall survival. So although, there may be some issues with the charted trial because, at least as of today, it hasn't been published yet, which is kind of interesting since it was presented a year ago. But I think when you see 2 trials pointing to survival benefit in this population of patients, we have to really say, okay, maybe there's some issues here and there, but we have to go with this data.
It might be possible that they're waiting for the low volume metastatic group to mature more and see if that's a positive readout as well. But the third trial you're referring to, the French trial, Jetug
Yes.
trial,
Yes.
probably gives us the same signal. It was a much smaller trial, about 1/3 of the patient size, and the indicators are that it was reading in that direction, but probably was not powered well enough to
Right.
actually show the same results.
It
So I don't
wasn't
think
that
it's
large.
inconsistent, Raul. I just think it probably wasn't ideally designed to give us the same signal at the same time. But
Right, it was much smaller, and they had fewer patients with the so-called high volume disease when they went back and looked at it. So it's very possible. You're right. I agree with you. Even though you're a urologist.
Do we know in either chartered or Stampede, have they broken this down yet to what percentage of patients had already been treated by a urologist for primarily and then progressed? Is that number available yet? Do you know?
a very small percentage had local therapy. I was actually surprised. It was about, I believe, 10 to 15% had some local therapy. I'm not sure under what circumstances, especially those who had surgery, because it really wouldn't be an indication to treat the patients with a radical prostatectomy in light of their stage. But I think a little over 10% might have had a prostatectomy. So
I don't think that data has actually been presented. I'm not sure if it's been presented or not, but it would make sense from the standpoint that there's now this, if you go back and look at some of the SWOG data from Taxotere, those patients who had a radical prostatectomy and received Taxotere had the best overall survival. And in other words, what you're saying is that the local treatment, there's now a trend towards looking at doing these kitchen sink approaches where patients are treated with maximal hormone therapy, then undergo a prostatectomy, and then have their different sites of metastases radiated. It's still, of course, still investigational, but I would wonder whether there's a real difference in how these patients were treated locally in the European study that was from France versus the charted trial. And I think that would be very, very interesting to analyze the data from that standpoint.